Hey everybody, Dr. Danielle Ward here, and today I'm hitting you with a little plastic surgery education, and we will be discussing hand surgery. So stay tuned and let's get it. Welcome back to my channel. For those who don't know me, I am Dr. Danielle Ward. I am currently a fourth-year plastic surgery resident physician, and today I wanted to discuss hand surgery as a continuation of my plastic surgery education topics. So for those of you who have been following my blog for a while back I did do a video covering flap surgery and how that pertains to plastic surgery and what we do as plastic surgeons when it comes to flaps. I'd like to continue an educational series where I cover common aspects of plastic surgery that the general public don't seem to know about, because a lot of times people hear plastic surgery and they think the aesthetics, they think the breast augmentations, the tummy tucks, but they don't realize what a lot of plastic surgeons do. So my goal is to have an educational series where I break down important topics within plastic surgery, whether that's craniofacial, soft tissue reconstruction, flaps, hand surgery, gender affirming surgery, everything that we cover as plastic surgeons so that the general public can get an idea of what we do. This is not meant to be fully educational for those of you who are in residency or medical school, so don't come at me too hard if I mispronounce something or don't get too in-depth into a topic. But what I'd really like to do is just show people a little bit of our world so that they can appreciate plastic and reconstructive surgery as a whole. So today the topic we will be covering is hand surgery, and I'm excited to share a little bit of knowledge about it with you all. So a lot of people tend to think of hand surgery as something that is done solely by orthopedic surgeons, but surprise, plastic surgeons also perform hand surgery as well. It actually is interchangeable. So a lot of times at different hospitals, if you come in with a hand injury, depending on if it's just soft tissue, it's likely going to be a plastic surgeon seeing it. If it involves bone and soft tissue, some hospitals will require orthopedics to see it. And then a lot of times it's interchangeable. I know at some hospitals where I'm at, ortho will see it if there is a bone fracture involved. But other hospitals, plastic surgery gets called in because we both can do the same thing when it comes to the hand. And when I refer to hand surgery, I'm not just talking about, your fingers. Hand actually encompasses the hand, the wrist, the entire forearm. We cover a lot. We learn a lot. It's actually for me, it's one of the hardest topics and the most extensive. Just to give an example, I have one of our, well, it's not our textbook. It's one of the books that I use to study from, like at Essentials of Plastic Surgery. But if you look, just the hand section alone takes up a large amount of this book. This is just little facts that we're supposed to know in hand. So this video will not be as extensive, but I do want to give you guys, just a peek into what we cover. So just to get started, let's go over some basic hand anatomy, starting with the fingers. So one thing that a lot of people get confused about is we don't actually refer to the fingers as numbers. Some people will say first digit, second digit, third digit, so-and-so, but a lot of people tend to get confused between the thumb or the little finger being a number 1. So we actually refer to the fingers by their names. So you have your thumb, you have your index finger, your middle finger, which some people will refer to as the long finger, your ring finger, and your little finger. It's very simple. We also use a lot of acronyms in plastic surgery, especially when it comes to hand, because there is so much to learn. So the next part of the anatomy would be your joint. So we would say like your IP joint, your interphalangeal joint, your DIP joint, which would be your distal interphalangeal joint. Your PIP is proximal, and distal just means furthest away, whereas proximal is closest. You have your metacarpal phalangeal. I'll put a picture up so that you can see what that is. Your carpal metacarpal joints and your disc radial ulnar joints. There are also a lot of muscles within a hand, and we abbreviate all those as well. So I'm just going to put up a picture right here so you can see. because I think this is one of the things that trips me up the most when you're like APL, EPB, PL, QP. So this is just to give you an idea of all the muscles. I will not go through them. Like I said, this is just designed to get the general public knowledge of what we do. So this is just the basic anatomy that I'm covering. We also break up the hand between extensors, and that's just what allows you to extend your hand, versus flexors, which allows you to flex.
Oh yeah!
There are also 6 dorsal wrist compartments that we're expected to know. I won't, go in depth into them, but there is a good mnemonic that I use for the first one. It's Applebee's. So you have your APL and EPB, just for those of you who want to remember that first dorsal compartment. And then I just kind of break it up into ECRL, ECRB for the second. I just remember that's, the second longest. Your third is your EPL, just 3. And then for the fourth, I remember the EDC, the extensor digiti communis, as like your fourth just communates. I make up weird things when I'm learning, but it somehow sticks with me. And then for the fifth, it's extensor digiti mini-me. I just think like your hand is mini-me. And then for the sixth, I just remember that as EDU, like ulnaris. You're on your ulnaris side. That's the furthest side. But don't worry, I won't, confuse everybody with that. That's just like the Applebee's, the APL, EPB. That was just the fun thing I learned when I was on hand surgery that stuck with me. I'm really good with mnemonics and weird sayings, so maybe that will help one of you. And there are extensor and flexor zones and dorsal wrist compartments. I won't get into all of that because, like I said, it is pretty extensive. Just the basics. Just know that for plastic surgery, when it comes to anatomy, we're covering the joints, the bones, the tissues, all the muscles, forearm. It's the whole entire upper extremity that we cover. But we have to know every muscle, every tendon, every joint. It's pretty extensive, so let's get into general topics within hand for plastic surgery, just so you guys don't run away from me. So let's kick it off with congenital hand disorders. What this means is dealing with the hand in infants, babies, small children. So what you might see with these disorders are things like syndactyly, I'll put pictures up, camptodactyly, clinodactyly, polydactyly, mirror hand, and macrodactyly. We also cover things like brachiodactyly, ambiotic band syndrome, and in conjunction with other parts of the body, we have things like Apert syndrome and Poland syndrome. Poland syndrome is actually when you have an absence of the major head of the pectoralis muscle and an absence of the breast. But in a lot of these patients, you can see syndactyly. So that is something that we treat. So for those of you who don't know, your hand develops within weeks 4 through 8. So congenital hand disorders are classified into types based on this development. So with type 1, you have a failure of the formation of parts. So this can result in your typical cleft hand. In type 2, you have a failure of differentiation, the separation of parts. So with this, you can see a few things. You can see syndactyly, camptodactyly, clinodactyly, or symbrachiodactyly. In type 3, these are your duplication, which means double, multiply disorders. And with these, you will see mirror hand, polydactyly, or things like triphalangeal thumb. Type 4 is an overgrowth, so that's where you get like the macrodactyly. Type 5 is your undergrowth, so that's where you get your brachiodactyly. And remember, brachy, that beginning part means slow, so brachiodactyly, underdeveloped, or your thumb hypoplasia. And then you have type 6 and 7. So type 6 is your constriction band syndrome, and type 7 includes generalized skeletal deformities, which can include Apert syndrome, thrombocytopenia, absent radius syndrome, or Poland syndrome. So what do all these words mean? So let's start with syndactyly. This is a failure of differentiation separation disorder. So this is when you typically see the fingers are fused together. And how do we as plastic surgeons treat that? Well, a lot of times we do flaps or Z-plasties to open that up and create flaps to separate the fingers and have them all be separate. Next is camptodactyly, which is just the painless flexion contracture of the little finger, IP joint. And how we treat this, it's just passive stretching and watching. It doesn't typically require surgery. The other one is clinodactyly, which is a C-shaped curvature of the little finger, what typically occurs in the little finger. We also observe this as well. Next is your polydactyly, which are your duplication having more than disorders. And these can either be preaxial, and when I say that, we mean on the thumb side, or postaxial, which is on the owner side. So preaxial, postaxial. In plastic surgery, we often get tested on this as it pertains to the thumb, and there's actually a classification system that we use, and this is known as the Wastel classification system of duplicated thumbs, and it's basically just 7 classifications. The first is when you have a bifid distal phalanx. The second is when you have a duplicated distal phalanx, which means it's not bifid, it's just completely separated, it looks like a V. Your third is a bifid proximal phalanx. The fourth is when it's duplicated proximal phalanx. The fifth is your bifid metacarpal phalanx. And the sixth is a duplicated metacarpal phalanx. And lastly, your seventh has a triphalangeal component, but the most common out of all these is your type 4, which you have the duplicated proximal phalanx. I won't dive deep, but basically when we encounter these congenital hand disorders, it does involve excisions, it involves flaps, it also involves a lot of times us placing the nerves back together, tendons, all of that. So that is why this is important to plastic surgery. So going into another section of hand surgery, we will discuss your hand masses, your vascular disorders, and your Dupuytren's contractures. So hand masses, there are so many, and actually as a former urgent care physician, I actually used to deal with some of these a lot in an urgent care setting. One of the most common that I would deal with would be a ganglion cyst. So this is a translucent cyst that you usually see in between a joint area. There's an old wives' tale where you could slam a book on it and it goes away. In urgent care setting, a lot of times, obviously I wasn't doing a full excision of the cyst, although it can return if you don't fully excise it. I would just put in an 18 gauge needle, drain it, patients would be happy, and then I'd tell them to see a hand surgeon. But can't get away from it because in plastic surgery, we also deal with that as well. So common masses that we deal with as plastic surgeons include the ganglion cyst, but we also deal with mucus cysts, epidermal inclusion cysts, lipomas, which is just like fatty tissue under the skin or in the arms. We've removed a lot of those. Giant cell tumors, that's another thing that I removed a lot of on my hand surgery rotation, which is actually really cool to see. Pyogenic granulomas, schwannomas, which is it's invading, like the median nerve within the hand that you have to take that out. And then things like endochondromas, osteochondromas, osteoid osteomas, the list goes on and on. When it comes to vascular malformations of the hand, we deal with things like vascular aneurysms. There's a Hammer syndrome that we deal with. We also deal with vascular malformations, hemangiomas, glomus tumors. There's a lot of masses and vascular things in the hand. I also mentioned Dupuytren's contractures. This is something we see in a lot of older individuals. And what this is a benign fibrous conditions where the hands will actually be contracted due to the fibrous connective tissue. And these are actually some of the cases that I find super fun. A lot of times we take the percutaneous approach where you take a needle and you go in and you just break up those bands, and the patient goes from, you know, being like this, not able to move it, and then all of a sudden, boom, they're able to open and close their wrists, like right there on the table. So it's immediate gratification. It's a good case to do. We also did fat grafting into it just to kind of keep the gliding and give it the nutrients as needed. So I thought that was one of the cool cases we did in hand. Having covered trauma plastics, we've seen a lot of hand fractures and dislocations. I cannot tell you how many I have seen because it's been a lot. But I'm constantly, like whenever I'm covering plastic trauma or hand surgery, constantly under the C-arm, which is this big X-ray you put the hand on and you can work under it. So we're doing things like sticking K-wires within a fracture. We're opening up, we do a lot of distal radius fractures. So we will open up, just, you know, cut here, you can see the muscle, you move that, you go down to the bone, you fixate that, usually using plates with screws, which is really fun doing. And then we also tend to do a carpal tunnel release because that can get constricted. That's actually one of my favorite cases, is doing it. Hand cases is doing an endoscopic carpal tunnel release because it's just so fast and it's so satisfying. So with the fractures, we do a lot of radius, ulnar, hand fractures, you name it, in plastic surgery. We also deal with things like nail bed injuries. I don't know if you've ever slammed your finger in the door and then you see that there's a blood collection under that. I actually dealt with a lot of that in urgent care too. And a lot of times in urgent care, I would do trepanation, which is, I would just drill a nail in there, release the blood, they would feel better. But since being in plastic surgery resident, I've learned the importance of actually removing that nail bed completely, because a lot of times there is a laceration under there that needs to be repaired. So removing that, repairing that tissue, replacing it with an artificial nail until the new nail grows back. And a lot of times we can do like a culture swab tube, the plastic, and make an artificial nail out of that, or take the patient's nail and just kind of sew that back in. So that's been really cool. And then it's also important to always check for fractures with those, because you might not think, oh, it's just, you know, you might think someone just sliced themselves with a knife cutting an avocado, but sometimes I've seen that they go straight down to the bone. So that's another thing that we do. And speaking of bone, dealing with a lot of finger amputations, whether it's, you know, using a knife to cut an avocado and, you know, chopping off the top of someone's finger, or someone actually slicing off their finger. We've had parts come in. It's actually a really cool case to be able to do a digit reimplantation where you put, you know, the nerve, the tendons, the tissues, all of that back together. And when it survives, it's a great thing. So that's another fun aspect of hand surgery that plastic surgeons take part in. And of course, we deal with things within hand like arthritis and carpal tunnel syndrome, which I've also mentioned. I think for me, one of my favorite things to do when it comes to hand cases are extensor tendon injuries. And I remember I had a patient that I saw, I don't think it was a trauma patient, I think I saw them in the ER, and they had, you know, cut themselves while working, could not extend their finger for anything. And then, you know, I came in, I noticed that the extensor tendon was completely cut, and I'll show you a little video here. I did get permission, this was a long time ago, so there's no patient identifiers, but the extensor tendon was actually cut pretty badly, sliced in half. It was a perfect cut. I was able to find the two ends, approximate them, sew it together, and then as you see in the video, immediately after I was done, the patient was able to extend their hand again. One of the coolest things ever. I don't have the sound on in the video that I'm showing you, but it was super cool because after I did it in the video, you hear the patient saying, "Let's go!" Yes, like the patient was so happy. So that's one of the fun things that I do, and it's something that can just be done in the ER at the bedside with a little lidocaine. So I would say out of the hand cases that I do on my own, that would be one of them. What are the perks of hand surgery? So for me, one of the things that I really enjoyed about my hand surgery month is it's a lot more comfortable than the regular plastic stuff we do. And by that, I say a lot of the cases, you're comfortably sitting in a chair, working on the individual, so you're not standing on your feet all day. And I say this having just did a 16-hour case on something else the other day, and it takes a lot out of you. But hand, you're comfortable. A lot of the cases were super fast. I know when on my hand surgery rotation, they could do a carpal tunnel surgery. We counted once, and it was 2 minutes, and we would knock out about like 15 to 20 surgeries a day. So I got a lot of cases from that. The lifestyle's pretty good in hand surgery. And, you know, it's not bad. You still get the variety where you're getting the masses, you're getting the tendons, you're getting congenital if you want that, or trauma. So those are some of the perks that I found personally to going to hand surgery. As for the pathways of hand surgery, you don't have to be an orthopedic surgeon to be a hand surgeon, like I said. There are actually 3 different pathways you can take to go into hand surgery if that's what you find you enjoy. You can do an orthopedic surgery residency, a plastic surgery residency, or a general surgery residency. And then after, a lot of people do a 1-year hand surgery fellowship and then go on to become hand surgeons. Do you have to do the fellowship? Not necessarily. One of my attendings actually did not do a fellowship and is strictly a hand surgeon, but I will say that a lot of hospitals for certification and privileges, to be called a hand surgeon, they do want you to do a fellowship. So if hand is something that you find super fascinating and you think you want to do, don't necessarily think that you have to become a plastic surgeon or orthopedic surgeon to get that. You can also go into general surgery. But like I said, hand surgery is so extensive that I just wanted to take the time to record this video to give the general public a very brief glimpse into what it is that we do when it comes into hand surgery as a plastic surgeon. Like I said, it's very involved. As plastic and reconstructive surgeons, we deal with the entire body, but when it comes to hand specifically, we deal with the entire upper extremity. So there's not much, whether it's, the elbow, the wrist, the fingers, putting nerves and arteries back together, tendons, lengthening those, or transpositioning, which I won't get into. We do it all. So hopefully this helps give you a little bit of appreciation for hand surgery and how us as plastic surgeons and plastic surgeons in training like myself deal with the hand. And if you like what you see, please subscribe. Let me know if there's any educational video that you'd like me to cover. Like I said before, I do plan to have an educational series covering different topics of plastic and reconstructive surgery so that the general public can get an idea and appreciation for us plastic surgeons. But until next time, thank you so much for watching. Don't forget to subscribe, and I'll see you soon. Bye.